afternoon, my dear colleagues and friends. And before starting, I must thanks the Dr. Rajesh and his full team of this Gujarat Critical Care Society for this this excellent arrangement and with good gatherings. And I think this topic is very relevant right now because gradually we are coming across with some problem that that is very simply the drug resistance, because in last 5 to 10 years there was no new drugs in antibiotic era that actually is helpful. And right now most of the time when I enter in my critical care unit, it is either okay, it is sensitive to carbapenems or colistin, so I need not to think too much if the patient is having some problem of hospital or healthcare associated infection. Only I need to think once the patient is coming from the community, then I need to scratch my head to find out some of the antibiotic choice. And common infection in the community which we come across is basically community acquired pneumonia or respiratory tract infection, the urinary tract infection, skin soft tissues infection. That's why I will cover most of the year. And what are the biggest concern, and what we are facing the problem is basically more resistant cases, huge burden of the ESBL, different type of ESBL, AMC producer, the newer New Delhi beta lactamase, then KPCs. So these organisms are coming up, and it is also prevalent in the community. So that's why I don't know how much of all these guidelines will be helpful in our practice, but it is high time we should think and we should restrict using these antibiotics. And this is the different phases of the beta lactamases, and at this moment in the Asia and the southeastern in our Asia and in our part, the ESBL producer E. coli as well as Klebsiella, they are almost 20 to 25% prevalent in our hospital settings. And about the community setting, till now it is around 15 to 20% with very minimum data whatever is available. And first I will discuss about the community acquired pneumonia. This is basically some of the organisms which are common in community acquired pneumonia is streptopneumonia, Haemophilus influenzae, atypical organisms like Mycoplasma, Klebsiella, Mycoplasma, chlamydia, and viral infection. They are relatively lesser in number, but still they are prevalent. And if we look at the resistance pattern, gradually the streptococcal pneumonia, they are getting resistant in the community also. So that's why the choice of antibiotics should be very pertinent, and every time it should be evaluated if we have data about the MIC of the streptococcus pneumoniae. So otherwise it will be very difficult. And once I come to the initial empirical therapy, so mostly I will cover about the empirical therapy before the actual culture report comes, because once we will get the culture reports, then it will be much easier to select one of the narrow spectrum antibiotics that will be applicable for my patient. So a patient, once a patient comes with the respiratory tract infection, first we have to take decision what type of patient it is and where this patient needs to be admitted. It may be in the outpatient department, it may be in the indoor patient or ICU patient. If the patient comes to the OPD outdoor basis and the patient was healthy without any use of the antibiotics in last 3 months, then the macrolides like azithromycin, clarithromycin, and doxycycline would be a choice, because here we can take a chance that this patient is not sick, so we can give a chance to improve. If the patient is not improving, or there are some comorbidities, or there is history of antibiotics used in the last 3 months, then it will be judicial choice will be fluoroquinolones, respiratory fluoroquinolones like gatiploxacillin, levofloxacillin, all these group of moxifloxacillin. And otherwise the second alternative choice is beta lactam like cefuroxime, amoxiclav plus macrolides. This can also be used, but again concern is right now the CDC has given warning about the levofloxacillin use, because it actually creates as well as encourages ESBL formation, ESBL producing organism. The same thing is true about the amoxicillin clavulanate also. And if high incidence of macrolide resistance is there in the community, then the obvious choice will be or quinolones like levofloxacillin or moxifloxacillin, because there will be no other choice that can be given orally. And if the patient is getting admitted in the hospital and patient is in the ward, then the choice may be IV quinolones or afterwards oral quinolone, or patient may be put on the 3rd generation cephalosporin like ceftazidime, ceftriaxone plus azithromycin or doxycycline. because these atypical are basically why it is important, because all these atypical organisms has no cell wall. So that's why we need to give these organisms, these antibiotics, where they work by the intermediate, not exactly hitting in the cell wall. And in the ICU, once the patient is in the ICU, then our choice should be ceftriaxone or ceftazidime plus aminoglycoside and macrolides or respiratory quinolones. And if patient is allergic to the any of the penicillin group, then aztreonam may be a choice in place of the ceftazidime or cephalosporin. But some patient, if there is a doubt about the pseudomonas, like a patient with bronchiectasis, COPD with recurrent use of the antibiotics, then the antibiotic choice should be an anti-pseudomonal agent like piptaz, meropenem plus ciprofloxacillin. Here the combining two antibiotics, there are debate about whether single drug, two drugs. Till now the IDSA and other most of the society, even our Indian Society of the Chest Physicians, they also recommend this combination. And if there is a doubt about the MRSA, like the patient is on dialysis, IV drug use, so then MRSA cover should be given by IV vancomycin or linezolid. Which one should be chosen? That depending on the price as well as considering the VRE, the vancomycin would be better. And if there is a chance of viral pneumonia like influenza A, pandemic flu, not all patients, but some of the patient, if he is having some complications or patient is having pneumonia from this influenza infection, within 24 to 48 hours if patient presents, then we can give antiviral drugs like as oseltamivir, zanamivir, that can be given. And once the patient is relatively better, can take orally, then we can switch over to the oral medicines if suitable with suitable alternative. And about the duration of therapy, usually for the streptopneumonia it is 7 to 10 days. And in the most of the pneumonia, particularly bacterial pneumonia, the right now duration has been fixed up around 7 to 8 days. But there are specific situations like atypical pneumonia, so then the coverage should be about 2 to 3 weeks. And regarding the skin infection, there are different type of skin infection that can happen. And first we should clinically judge whether my patient is suffering from some cellulitis, then whether purulent cellulitis or not, or my patient is having extensive infection of the limb, that we call it as necrotizing infection. So if you look at the skin structure, usually the epidermis and subepidermal layer gets involved with streptococcal infection. Sometimes the staphylococcal infection may be there. But if there is fascial involvement of the muscle involvement, then most likely this patient is suffering from necrotizing fasciitis, and then the organisms will be either staphylococcus along with the other organisms like gram-negative streptococcus. So it is basically polymicrobial infection. So in cellulitis patient, the commonest cellulitis patient without purulency is basically streptococcal beta hemolytic streptococci. The role of MRSA or any staphylococcus is relatively less, so that's why we should not think about staphylococcal infection. And coverage for the staphylococcal infection should not be given if there is relatively purulency is not there. And if there is purulent cellulitis, so then the chance of the staphylococcal infection along with the streptococcal infection is there, but the staphylococcus is outnumbered than the streptococcal infection. And once there is the staphylococcal infection is there, right now there is also community acquired MRSA, so that is one of the possibility. If patient is relatively moderate to severe degree of illness is there, then we should think about the MRSA, and MRSA number is gradually increasing. And not only that, along with the MRSA, there is also vancomycin resistant staphylococcal infection that is also gradually increasing in number. So then the empiric choice for this kind of cellulitis, where the patient is relatively stable with purulent, then the choice should be both, we should cover the MRSA as well as streptococci. So for that streptococcal infection, the third generation cephalosporin or the penicillins like Amoco, amoxicillin or amoxicillin, plus if we want to give MRSA cover, then oral choice is there or the IV choice. For the relatively less sicker patient, we can give a choice for the trimethoprim sulfamethoxazole or doxycycline. And if we are covering with the clindamycin, because it has very good cover for the MRSA as well as the streptococci, so it is sufficient, but the dose should be 900 milligram 3 times a day. And for the very severe cellulitis, where the patient is also having the systemic inflammatory response syndrome in the form of fever, the patient is relatively toxic or hypotension is there, then the IV vancomycin along with piperacillin, tazobactam or carbapenems may be given. And for the patient who are allergic to penicillin, then the suitable choice will be vancomycin plus ciprofloxacillin. And this is the classic picture of the necrotizing fasciitis, where there is involvement of the skin, soft tissue as well as fascia and muscle involvement. And obviously patient will complain of the pain, severe degree of pain in these areas. And for the necrotizing fasciitis, it is basically polymicrobial. That's why our coverage should be vancomycin, linezolid, plus piperacillin, tazobactam or any carbapenems, because we need to also give cover of the anaerobes, particularly anaerobic streptococci, as well as once the patient is getting better or there is any pus that we will get cultured, if it is positive for any narrow spectrum or any particular organism, then we can de-escalate the therapy. And regarding the vancomycin, it is very important that right now the vancomycin trap concentration, that is the concentration before giving the next dose of antibiotics, the concentration should be 15 to 20 milligram per liter in the blood. And this trap concentration should be maintained, otherwise there is a possibility or chance of getting vancomycin resistant staphylococci. And the dose for the initial part, we should start with 15 to 20 milligram per kg of body weight, then we can gradually reduce the dose depending on the creatine clearance as well as trap level of vancomycin. And there are other specific type of the infection in the skin, like pseudomonas infection in the neutropenic patient, or sometimes there are any diabetic foot ulcer, that will be any again polymicrobial. So this type of infection we should choose antibiotics according to the organism that will be cultured from the wound. And about the urinary tract infection, there are different guidelines right now, IDSA guidelines, there are European guidelines, but problem is with the E. coli is the one of the commonest organism, and E. coli right now, because of the massive ESBL producer organism and the resistance pattern. So whether this evidence will be good enough for us or not, that we have to judge, because these guidelines are quite excellent and helpful for us. However, our own guidelines should be there in this particular urinary tract infection. And if we look at the different organisms, it is the most commonest organism is E. coli in the community, followed by other organisms like Klebsiella, Staph epidermis, Enterococcus faecalis. So we should always keep in mind that the 70 to 90% cases are E. coli and rest are basically either Klebsiella or other organisms. And there are different kind of scenarios that can happen, that patient might have cystitis or patient may have pyelonephritis, complicated, uncomplicated, asymptomatic bacteriuria, and rarely we may also come across with patient with a catheter, prolonged catheterization for either bladder outlet obstruction or any spinal cord injury. For the acute uncomplicated cystitis, the choice will be basically E. coli and patient is not having any symptoms, then nitrofurantoin may be a choice with 100 milligram twice daily for 5 days. Here the duration of the antibiotics, different guidelines as there, and that is another Glasgow guidelines. They have categorically made it clear that the dose should be not more than 3 days, because again more than 3 days there is a high chance of getting resistance. Trimethoprim sulfamethoxazole that in double strength may be given twice daily for 3 days, and fosfomycin 3 gram single dose may be given, and pembrolizumab 400 milligram twice daily 5 days. This is not available in our country. So these are the alternative choice, but the first choice for the most of the guidelines are either nitrofurantoin or trimethoprim sulfamethoxazole. And in the study, head-to-head comparison study, the trimethoprim sulfamethoxazole versus nitrofurantoin, they are equivalent, so any one may be chosen. And about the acute pyelonephritis, uncomplicated, then the choice, if the patient is relatively not hospitalized, then choice may be oral ciprofloxacillin, that may be given for the 7 days, and levofloxacillin may be also as an alternative agent. But here the problem is, if the patient is responding very nicely, then 7 days is okay. But when the patient is not responding, then the duration of the therapy should be increased to 7 to 14 days. And if there is a chance that this, in the community, that the resistance of these quinolones are more than 10 to 20%, then the first dose we may give ceftriaxone 1 gram or aminoglycoside cumulative dose. Cumulative dose means basically once daily dose, like the amikacin 10 milligram per kg of body weight, 1 dose. Then we start it, then we can continue with the ciprofloxacillin or levofloxacillin, and then we need to look at the response of the therapy. And this ciprofloxacillin, once the patient is able to take orally, then ciprofloxacillin may be given by the oral dose. And trimethoprim, sulfamethoxazole, or the third generation cephalosporin is not a good choice in these scenarios, because two things are important: because of the very high resistance pattern in the E. coli or Klebsiella of this group of organism, as well as they can induce this resistant organism. And if the patient is relatively sicker and needs hospitalization, then injectable quinolone plus aminoglycoside may be started, and rarely we may also give the aminopenicillin and beta-lactamase inhibitor like piperacillin tazobactam, and the carbapenem may be started as a desperate measure, and then later on we can de-escalate the therapy. And this asymptomatic bacteria is basically where there is no symptom, but still patient is having the colony count urine, there is pus cell, as well as the colony count is more than 10 to the power 5. Then this group of patient, not all that group needs treatment, but there are pregnancy that needs to be treated, because about 20% of these pregnant patients who are basically asymptomatic bacteriuria, they may go into later on in the urinary tract infection that can cause adverse outcome of the pregnancy. And if there is, we are planning to go for some intervention in the urology side, like breach in the bladder wall or prosthetic surgery, then we should also give treatment. In another group, if an woman with the postmenopausal age, we have taken out the catheter after brief period of catheterization, and if this patient develops the bacteria after usually 48 hours, then that group should also be treated. And usual duration is 3 to 7 days, and antibiotics more or less similar to the cystitis, either nitrofurantoin or trimethoprim and sulfamethoxazole. And about the catheter-associated urinary tract infection, because right now long-term, short-term, long-term catheterization are very commonly used in the IA, and some of the patients, they are living with that catheter throughout their life. And this group of patients is basically, they are either maybe symptomatic or asymptomatic. If the patient is catheter-associated asymptomatic bacteria, no treatment is required except for the pregnancy, or we are planning for some intervention. And if the patient is having catheter-associated urinary tract infection, and patient is having symptoms of the urinary tract infection, then about this group, they are very resistant and they are polymicrobial. That's why antibiotic choice is really difficult at this phase. And early resolution of, if we give usually the quinolones or nitrofurantoin is not a good choice here, then quinolone we can choose, or a third generation cephalosporin in this group may be given. And then if the resolution of symptoms is good, then the duration of therapy is 7 days. But the group of patients who have delayed response, then 10 to 14 days should be given. And levofloxacillin for the 5 dose, 750 milligram daily for 5 days, there are some study, they have shown that it may also be chosen, but it is basically, according to the evidence, is lower grade. That's why it is not always advisable. So 7 to 14 days is good choice depending on the response of the patient. Then about the cystitis or catheter, if the patient, we have removed the catheter and this patient develops some kind of the urinary tract infection, then here we may give us without any prior history of antibiotics, 3 days course may be given. So in summary, we need to have our own guidelines based on our own data as well as local microbial susceptibility. We should have strong national and local policy that needs to be developed, and this policy should be revised every 2 to 3 years because of the very high degree of resistance. And we should always think about, by prescription, giving prescription, always we should look for the collateral damage, as well as whether we are inducing any kind of MDR or pan-drug resistant organism, so that we should look for. That's why the duration of antibiotics as well as dosing should be restricted. Okay, with this I must thanks and
Thank you, Dr. Panja, for an excellent presentation. Any lecture for Dr. Panja? Any question?
Sorry, actually that is about 15, 15 milligram per kg of body weight as a single dose.
Okay. And if you have a community acquired pneumonia in a patient who is not bringing out sputum, what will be your choice? It will be azithromycin, I mean a macrolide or a doxycycline?
About the doxycycline is the data not good enough. So in that case, azithromycin or the clarithromycin maybe all these guidelines in our Indian guidelines as well as the guidelines by the IDSA and other society, they have put it as alternative is doxycycline. But I think most of the authorities as well as the expert, they feel that the macrolide should be a better choice. And about the, unless we get the sputum, so to get and collect the data is another a big problem. That's why the number of study as well as the evidence is not very strong in this.
Thank you.
Many diabetic postmenopausal females have chronic cystitis and have persistent asymptomatic bacteriuria. Would you treat them?
No. For any kind of bacteria, we need not to treat it. Even with catheter or if the patient is not symptomatic, we need not to treat. Only 3 group of patients, as I told, the pregnancy, as well as when we are going for some intervention where there will be a breach in the bladder wall. And third group is basically once we have taken out the catheter
in the... They have a thickened bladder wall. So would you treat or would you not?
No. In diabetic, no.
Sir, I have one question. A patient is taking clindamycin, 300 milligram, 4 times a day, IV, for 2 months. Then what are the side effects?
Excuse me, 300 milligram of?
3 milligram of clindamycin.
300 milligram of clindamycin.
Every 6 hourly, for IV, for 2 months. What are the side effects, systemic side effects? Or any other?
Actually, with all...
Is it advisable or not?
No, it is obviously not advisable. Unless I don't, basically there is still now, I don't know any data about all these things. And what about the clindamycin or any antibiotics? Whenever we are prescribing right now, there is problem of having this diarrhea as well as Clostridium difficile related gut infection. That is very common with any antibiotics, and amongst them the clindamycin is the notorious one.
He has Staphylococcal aureus infection.
For the Staphylococcal aureus infection, I don't think there is any guidelines that have suggested for this kind of longer duration. Only there is one study. What they did actually, the patient was developing recurrent MRSA. So in that group, they had given 6 weeks interval dose of the clindamycin plus rifampicin for the 6 repeated cycles of 8 cycles. So, but every cycle was 7 days only, because this patient, some of these patients of that particular author actually was not being cleared from the MRSA. So that is why he had suggested that one. Along with that, the mupirocin, that nasal ointment, and chlorhexidine bath he used.
But side effects are there or not?
Other side effects
and
are there.
What types?
Other side effects are your hematological side effects. Then patient might have hematology in the form of, say, leukopenia, thrombocytopenia, and GI side effects are there. So these side effects will be there, and there are other number of side effects with the clindamycin. But this duration of clindamycin, I don't think anyone will suggest.
And with this antibiotic, he is bedridden. He is not advised to move.
Excuse me?
He is not advised to move from the bed.
No, I don't.
He is bedridden with this antibiotic treatment.
I think better if you have that contact number, ask that patient not to take that antibiotics, with apology to that doctor.
Thanks.
I'm sorry you are seeing me again back, but it's just a gap of around 10 minutes, and because Dr. Nirmal Jaiswal has missed 2 flights today to reach to Ahmedabad, and last flight when he landed is on from airport, and I think I can't wait for him. So what I thought just 10 minutes before, I wanted to complete this topic, and we will definitely give you a better version what could have been come from lecture, what we have planned very quickly, a panel discussion for this commonly misused drug. A fourth drug I wanted to give you a guideline about soda bicarb use, about use of hypertonic saline. I wanted to give a guideline about the use of mannitol and albumin. We have all the experts sitting here, so you can also participate if you want to ask. So I think before lunch it will be little lighter also, but this topic I have selected because very often whenever we see reference, we see very commonly this drug being used whenever it's not required, and whenever it is required it's not being used. It's a very common practice for us, and that's the reason I have kept this topic as a discussion. Straightforward, I'll go to the soda bicarb. I feel very commonly misused drug. So I'll start my first question from Dr. Deepak Govil. Deepak, in your practice, when do you use soda bicarb? Just give me the grade 1 indication when you will use soda bicarb and when you will not use soda bicarb. Speaker.
Majority of those patients who are severely acidotic,
I think it's audible now. It's audible to all of you. That's fine.
having renal dysfunction, waiting for dialysis, and that time we correct their pH, try to correct their pH by soda bicarb. That is one indication. Another indication in ARDS, when PCO2 is high, pH is dropping down, to correct that we can use that.
Yes.
So these are two hardcore indications. That's it.
How do you use soda bicarb? You give bolus, you give infusion?
Majority of time we give infusion.
Do you have any calculation, or do you just give soda bicarb and monitor? Suppose if somebody say, I want to give soda bicarb in this patient, so how much soda bicarb I should give? What will you answer?
Many times people calculate, but usually I don't calculate. It's just an arbitrary thing.
Yes.
I must admit that it's a simple arbitrary thing.
Yes. RK Singh, you want to say something, sir? It's on.
Okay, soda bicarb use in the intensive care only and only if pH is really going down. For acute and chronic renal failures, the correct answer is not there. Patient waiting for dialysis, the patient is sick, 7.1 pH, okay, patient in shock, do I want to use it? I would really be scared of using it. Why? Because I'm changing the pH extracellular, but I'm actually trying and alter the intracellular pH. Because that soda bicarb, which is lying extracellular, getting converted into CO2 moving within the cell, the pH of the cell is going down. So if you ask me really, there's no role of soda bicarb in the intensive care.
Great.
If you have to use it, the limits are going down further and further. Previously 7.2, now 7.1, and I'm dead sure it is going to be less than 7 in a few years to
So
come.
one thing clear, before I give soda bicarb, I will look for the pH.
pH.
And if it is less than 7 point, as long as it is above 7.1, it will not, even lower down.
Yeah,
Maybe
I'll try.
you in DK you can say even 6.8 you don't want to use.
Second,
But
if I have to use, I'll try and calculate the actual dose.
that's fine, that's fine.
I exactly do not remember the dose,
No,
but
no, that-
the
we are not
recommendations are
discussing
for
about-
calculating the dose and then
and
giving.
then you give. But one
Second,
thing,
third,
yeah.
one more option.
Yeah.
Do not give bolus.
Yeah.
Third, give infusions.
Yeah.
Give it over 1 to 2 hours. Whatever dose you have calculated, do not push a bolus, because that will change the intracellular pH even faster, and cell death will occur. Mitochondrial pH will go down, and you tried to correct some issue, but you really created more trouble.
And
for
one
your
more thing I'll add to your version, that acidosis per se is again a protective response of the cell. Cell
body.
survives better in acid medium than alkaline. If extracellular medium become alkaline, chances of getting complicated cellular dysfunction is higher in alkaline medium than acidotic medium. So be very careful when you use soda bicarb. What Deepak has said, which I agree to, when somebody has CKD with hyperkalemia, that's one grade 1 indication to give soda bicarb. In ARDS network trial, what Deepak was saying, I also agree, when pH goes less than 7.2, CO2 goes up, and you're not able to maintain, then at the time soda bicarb is acceptable. But in general, soda bicarb used just to correct the acidosis is probably not acceptable at this time. Viper Singh, you wanted to say something? Then Soren, your turn come. I think anybody in audience, if any question, because this is an open house, this lecture I have made immediately open house. Any question, please ask us. We will be happy to answer you about, because soda bicarb is something which I can say all of you have used somewhere or someday. So that's the reason I'm discussing this topic. Sir, sir, once you answer, then I'll come to your question. Yeah, please.
Hello. You know, need not to mention too much because already, Dr. Deepak Govil has mentioned regarding the soda bicarb use. The message to the audience is you need to maintain your pH which is compatible with the sustenance of the life, whatever the cause may be. So obviously the grade 1 indications are when you are dealing with the hyperkalemia. So it's a pharmacological part of the pharmacological therapy on that part. But by and large to the audience, take home message is try to maintain your pH which is compatible with the sustenance of life, and that's a 7.2. If the metabolic cause is there, I am not going to the nitty-gritty and the detail of that because that's already available in a text. So definitely use is limited, but one has to remain cautious on that.
Soren, you want to add something?
No, just I was, another use is basically if there is some toxic, like
I will be coming to that. That's another thing. Yeah, Sunil, that's
Just an addition is, as you rightly said, DK, I think even 6.8, 6.9, we should not treat because
agreed.
the
Even in
clearance of
6.7,
ketones also
one
gets
thing,
affected.
One thing very
actually.
strong message I want to give you, house kids, for DK, whatever it is, whatever pH it is, if you give soda bicarb, it's going to kill your patient. Soda bicarb is strictly no for this hydration, conversion of ketone to alkaline, because once you start hydrating, giving insulin, ketone will get converted to alkaline and that will correct the pH. Don't give soda bicarb. One more indication is the class 1 indication is come for the drug overdose. Can you mention that, Soren? Just name the drug which people can use for alkalinizing urine. That is a classical indication for alkalinizing the urine, where you use soda bicarb. Yes.
The commonest one is amitriptyline poison.
Tricyclic antidepressant antidote. Here, soda bicarb is used as an antidote, and it's again a class 1 indication to use the drug.
One more for renal tubular acidosis. There it is still there.
Yeah.
There you do
Again-
it probably
again
because
it
you're
is
not able
again
to
to-
compensate for the losses. There you try and give it.
Again to alkalinize the urine and protect the tubules. That's fine. Sorry?
Even the other normal anion gap acidosis like GI loss
Yeah.
or renal loss, we could
Yes.
use still as to time buying measure
Again,
basically.
if you are measuring pH, patient is coming to you with acute gastroenteritis,